This is LiveWell Talk on COVID-19. I'm Dr. Dustin Arnold, Chief Medical Officer at UnityPoint Health, St. Luke's Hospital. In today's podcast, I'll cover the latest on COVID-19 vaccines and boosters that were recently approved for Moderna and Johnson and Johnson, as well as touch on the new Merck pill that's coming onto the market and update on natural immunity. We'll also have our first mailbag segment, our inaugural mailbag segment, where I'll answer some questions from the listeners. What we're seeing in the hospital is a persistent plateau that we've seen for several weeks, actually 6 weeks approximately. And that has been just a steady state of admissions in people that we're treating for COVID-19. And this is stayed to be about roughly 30% of the ICU volume is COVID-19, the rest being other medical conditions. Again, this is part of this volume is one is that we literally suspended healthcare for 6 months last year. And I think a lot of these medical conditions are chronic kidney disease and heart disease and diabetes that continue to progress. And those patients are now being admitted, and that's the consequences of that lockdown. I think looking back, I think we've learned a lot, and we probably should do things a little bit different next time. I think I'm not sure that telemedicine is the answer. Maybe that's not the right thing to do. It doesn't replace the office visit, but more to come on that. But that's something that I think will need to be addressed at some juncture. The FDA, they've been busy, their advisory committee. Last week, they approved a second dose, not a booster. They described it as a second dose for all J&J vaccines for people 18 years of age and older. If you read the news release, I found it interesting when you read that is the FDA did not independently review the data. They just took what the company said and made this decision. Now, I believe it's probably the right one. I just found that a little strange that they didn't review the data themselves. The shot with the Johnson & Johnson, the second dose can be 2 months from the first dose, but the preferred is to be 6 months for optimal, and that gives what I've described before as the immune system needs to learn how to make the antibody from the vaccine, and then needs to know how to remember the antibody, and that's why the 6 month window is probably optimal. Now, at the same time, Moderna was approved at a 19-0 was the vote of members of the advisory committee from the FDA to recommend that boosters be delivered for Moderna. And it does match the same as with the other messenger RNA, Pfizer vaccine. Individuals that are 65 years and older, high-risk professions, healthcare frontline workers, and any patient that you believe as a clinician may not have manifested an adequate response to the vaccine. And that would be patients that have had an organ transplant, are on chemotherapy, have some sort of chronic medical condition that prevents that. This week, General Colin Powell passed away, a true statesman, and was certainly visible at a time in my life when I was forming mentors, and I think he was someone to role model after, just on his professionalism and his statesmanship. But he passed away this week, and he was suffering from multiple myeloma, blood cancer, and that probably contributed, among other things, to him dying from COVID, even though he was fully vaccinated. So that's an individual that may have not have manifested an immune response that what we would desire. Also in the news this week was that the Nordic countries, Sweden, Norway, and Finland, they've paused on the Moderna vaccine for the risk of myocarditis. The CDC has not followed that. I continue to believe that the myocarditis is a risk, but it's very small. And that you may want to go with the Johnson & Johnson vaccine if you're truly concerned about that. It was male adolescents. I think if you're over the age of 30 and a male, you're fine. I know that the FDA and the CDC continue to monitor this, and we really haven't heard anything about whether or not a similar pause would occur here. I don't know if the Nordic countries had the ability to use Pfizer and Moderna and Johnson Johnson. I'm assuming that it's like the United States, as we know, we've talked on previous podcasts that Israel had only the Pfizer vaccine for availability. One question that I have that I need to answer, and I'll answer on a future podcast, is if your risk of developing myocarditis from the first shot and the second shot was a certain percentage, is that amplified if you get a third shot, or is it the same risk? And that's something that I want to answer personally and make recommendations on that. And that will come up in a future podcast, so maybe next week. The new oral antiviral from Merck, it's not available for use as a therapeutic for several weeks. The advisory committee from the FDA has reviewed the emergency use authorization application, and they'll make a final ruling, I believe, on November 30th. So hopefully by the end of the year, we'll have our oral antiviral that we can take to help prevent the virus from replicating, similar to other antivirals we've had. And I'm excited that can be available, and the sooner the better. Some questions that I'm asked and try to answer to the best of my ability is whether or not you can mix and match the messenger RNA vaccine. So you got the Pfizer, but then you get the booster shot with the Moderna. The advisory committee did approve that to occur if it's not available. The preference is that you use the original, and studies will be released soon that will actually break that down as far as what is the immune response when you mix and match. So hopefully I'll have that on future podcasts as well. The other update for this week is natural versus vaccine-induced immunity. There's been no additional information from that standpoint. I have heard of some studies that are being peer-reviewed and be released, which will give us a gauge on natural immunity versus vaccine-induced immunity. But let me say this unequivocally: the vaccine protect the vaccinated. If you receive the vaccine, your chances of developing death from the COVID is 11 times less than those that didn't receive the vaccine. That's first and foremost. The hospital is not overrun by side effects from vaccines, which indicates to me that they're safe. And likewise, the hospital is not overrun from individuals that are having it the second time, COVID-19. So it does reaffirm what we've said previously. Vaccines protect from disability and disease, but there is probably something there to natural immunity, which is more to come, and that will be confirmed over time. That is the COVID-19 update for this week. When we return from the break, we're going to have our first edition of the Mailbag, where I'll answer questions that have been submitted by the intelligent listeners who choose to listen to this podcast on a regular basis. Welcome back to the LiveWell talk on COVID-19. This is our first edition of the Mailbag, a new segment on the podcast where I will periodically answer questions from our listeners on trending topics, not only limited to COVID-19. However, this week's questions are all on COVID-19. Our first question is from Kelvin, and he is submitting that the turnaround times for COVID testing and the subsequent IV therapy, or the monoclonal antibody, is the earlier the better, and he's absolutely right. His question was framed in the standpoint of, do you actually need to have a positive test prior to getting the antibody? And you do. That is part of the inclusion criteria. It's still under the emergency use authorization from the CDC and the FDA specifically. And so you do have to have the positive test before we can give it to you. That's just the rules, so to speak. We have expanded it to include antigen testing if positive from commercial outlets, Walgreens, other pharmacies, if it comes back positive. We are accepting that. We didn't initially do that, but we think the high transmission in this community that we can confidently move forward by in delivering the therapy to eligible patients based upon those testing. Definitely, you have a 10-day window to give the monoclonal antibody, and the closer to the onset of symptoms, is better. And our goal really is to get it within 5 days. I'm not so sure that day 3 and day 5 are different, but I do think day 8 and day 5 are different, if that makes sense to the listeners. So we appreciate Kelvin's question. The nene's question from Joanne, where she was told that wearing a mask, you were breathing in toxin. Is that true or false? So the answer is false. Because if that was the case, then my surgeons who do surgery all day wearing masks would all be dropping over from these toxins. There has been anecdotes, and you must be wary the tyranny of the anecdote, but that individuals have retained carbon dioxide from not appropriately exchanging it through a mask. And I can imagine that you could put a non-approved or non-surgical mask on that would impair your respiratory status. And that's why the recommendation is to use the surgical grade mask. And it is like the analogy we've used previously on the podcast that there's no study that says I should put on a parachute to jump out of an airplane. It's just it's going to help, and that's understood. And I think the mask is the same way, that the mask is going to prevent the virus from being spread if you're infected, and it is a reasonable mitigation factor, and I do support masking. The next question is from Laura. She hears a lot that pregnant women are not getting vaccinated. What is their fear, and what is your recommendation for pregnant women? Well, the pregnant women, they're hesitant to get something new, i.e. the vaccines, because they're pregnant and they have a child, and we don't know the long-term consequences of that. Although as clinicians, and we review the scientific evidence, we review the American College of Obstetrics and Gynecology, the Organization for Maternal Fetal Medicine. I can't think of the abbreviation at this juncture, but at this time, but they both have recommended the vaccines are safe. We know that they protect the mother and the baby, and they're of value. But at the same time, we recognize that women have a sincere concern about the unknown, and we recognize that and respect that. But I do encourage pregnant women to receive the vaccine as well as the monoclonal antibody. And I'm actually quite proud of our obstetrical community for encouraging their patients and actually seeing the patients in the infusion center. The last question is from Chris, and his question is, with the news of the Pfizer vaccine coming for ages 5 to 11, can you give your perspective on vaccinated children? And do you know when the vaccination for children may be approved? The FDA Advisory Committee is meeting to consider the request from Pfizer and to amend its original emergency use authorization to drop that down. I think the meeting's scheduled actually for October 26th, which is next week. And then the Advisory Committee on Immunization Practices will meet in early November to make the final recommendation regarding this population. I'm a little hesitant to recommend it in children because the risk of serious illness is lower, and I think it should be individualized based upon the clinician and in this case the pediatrician or family practice doctor. In doing that, I look forward to the Advisory Committee on Immunization Practices. They'll meet on November 2nd, November 3rd. I think these individuals are well respected, and their recommendations will be sound, and we'll bring that back after that recommendations conclude, or after those recommendations are made. And that's all for the mailbag today. If you'd like to submit a question to the mailbag, go to unitypoint.org/mailbag. I'll answer questions about COVID-19, latest technologies and procedures, services provided at UnityPoint Health, and other medical topics going on in the community. Please note, however, the mailbag is not an alternative to a medical appointment or medical care, and any questions about personal symptoms or conditions need to be directed to your primary care physician or urgent care if the scenario warrants that. In case of emergency, call 911 or go to the nearest emergency department. Once again, you can submit your questions to me at unitypoint.org/mailbag. That's unitypoint.org/mailbag, MAILBAG. I look forward to hearing from our amazing listeners. Thank you for listening to COVID-19 Update. For more information on COVID-19 vaccines, please visit unitypoint.org. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.